So better late than never. So this was the 31st because we decided that every organization was doing something or the other on all the dates. So with lot of difficulty, we got this slot out. So we have very interesting speakers and very learned speakers and expert panelists and moderators. So I hope you all enjoy. So unfortunately, our president, Dr. Rupinder, is on the flight. Maybe will be joining a little later. So can I request our CVs? So the first speaker is Dr. Jaydeep Bhomik. So this is the session on fertility preservation in cervical cancers. So we educate ourselves a little more about how we can manage them better, because in spite of all screening guidelines, I think screening in India is actually at a very, very low of around 1% only. So I think we will still see them. So we should know how to manage them better. And we are also seeing patients at a very younger ages. So we have our two chairperson, Dr. Rema, who is the HOD at the Trivandrum RCC, and Dr. Janmejay Mahapatra, who is the Vice President Foxy and Treasurer of AGOI, and works as Associate Professor in the Department of Gynecology at AHPGIC. So over to both of you to conduct the session, please. Yeah, can you go to the next Jaydeep sir? Yes. I request Janmejay sir to kindly invite Dr. Jaydeep, and Dr. Emma can conclude, because Dr. Janmejay sir is in a difficult place where there is no network actually.
Okay, good evening everybody. This is Dr. Jaydeep needs no introduction. He's the head of the department of Gynec Onco at TMC Kolkata. His areas of interest is education and training in gynecological oncology, advanced cytoreductive surgery for ovarian cancer, robotic surgery in gynecological cancer, cervical screening and colposcopy. Important efforts have developed the Department of Gynecology in TMC Kolkata, introduction of super specialty DNB in formal postgraduate training in gynecologist oncology in India, founder president West Bengal chapter AGOI. Over to Jaydeep. He will speak on fertility preservation in cervical cancer.
Yes, welcoming Jaydeep sir. This is a very important topic, cancer cervix. We are hearing so much about the escalation of surgery. So let us hear from the expert himself, the new options of fertility preservation in fertility sparing surgery in cervical cancer. Over to you, Dr. Jaydeep.
Thank you very much. It was a very kind introduction. So whenever we talk about cancer, and something we couldn't imagine in the recent past also, that yes, we can have cancer and it's possible to have a baby as well. So it's a difficult proposition. It's a very challenging proposition, but it's not an impossible proposition. In the next few slides, in my presentation, next few minutes, I will be trying to not only go through what are the possibilities, but I would stress on a bit of the philosophy of fertility preservation, what is the actual need, and I will describe a few techniques of fertility preservation that has been possible. I'll highlight on the related research and the outcome of treatment.
Doctor, can everybody hear Dr. Bhomik? I can't hear him very well.
Yes. Yes.
You can hear.
A little softer, but I think you can go a little closer to the
mic. A little louder, Dr. Bhomik. I can't hear you.
Okay, I'm not used to shouting. Anyway,
we know that, sir. A little more louder, sir. We can hear you, but
yeah. Anyway, let's start. So today, again, we know that it is the second most common cancer in India, and less than 40% of these women are actually the childbearing age, and that's why this proposition is here, that whether we can preserve their fertility. But the problem is that there will be hardly any woman who will actually be fit for or having surgery for cervical cancer. Majority of our patients are very advanced stage. We were auditing our own data at a medical center, and in the last year we had done only 10 wartime hysterectomies. Of course, we have been doing more than 700 advanced surgeries for other reasons, but wartime hysterectomy was only 10. So it is extremely rare. Hardly any woman in India will have cervical cancer, which is treatable surgically. But still, I mean, we hope for a better future, and then we should think of preservation. Now, if I am treating cancer, of course.
I think Jaideep, if you come closer to the mic, no, then perhaps we can hear a little louder.
Yeah, thank you so much, Dr. Rupinder. We welcome you again.
Yeah, thanks a lot. Fine. Thanks, Bhagya.
Good evening,
Hear me
Rupinder.
better now.
Hi, good evening.
Good
Yeah,
evening.
please continue, Jaideep.
Okay, yes. So I hope I'm edible. Not edible.
Yeah, it's better. It's better.
You can hear me better. Okay.
Yeah,
So
yeah.
first preference, of course, life. Whenever we are treating cancer, the first thing we have to look after is to make sure the patient is alive beyond many, many years. So that is the first thing we have to take care of. And if we have preserved life, if the patient survives, then of course our patients are women. And the second thing we should think of is that preserving her femininity, that she should survive as a woman. And once that is achieved, the woman has been maintained as a woman. We have not removed every reproductive organ or the female organs in that woman, but also we have been able to fertility. So the order is like this: we preserve life first, then preserve femininity, and if you can preserve life and femininity, think of fertility. So that is the basic fundamental philosophy of treating cancer and thinking of fertility at the same time. So, like the goddess Isis of the Egyptian goddess, the goddess of preservation of womanhood, we should think in the similar way that of course, we are preserving the womanhood first, and if we can do that, we also preserve the potential for childbearing. I'll come to some data
Yes, remember to join, huh?
so that you understand that that potential is more important than the actual numbers. Okay. So the reason we bothered about preservation of femininity and fertility in cervical cancer patients, of course, it will have to be at a very early stage. And if I think it's early stage, then my staging will have to be very perfect. So exact measurement of the tumor, exact location, exact assessment of the lymph nodes, or any spray or metastatic spread will have to be properly assessed before we embark on fertility preservation in cervical cancer. Okay, and not all histologic types will be suitable. If there are adenocarcinoma, if there is mixed Mullerian tumor. Only today we had been operating on a patient with mixed Mullerian tumor of the cervix. So all histology subtypes will not be amenable for fertility preservation. Okay, so our standard treatment is radical hysterectomy, but the moment we do radical hysterectomy, we are actually losing fertility, but ovarian function can be preserved. So we can preserve the ovary and still do the radical hysterectomy. So the femininity can be preserved, but the fertility is lost. Okay, but if we give chemoradiation, we are actually risking both femininity and fertility, because even if we relocate the ovaries in the upper part of the abdomen, still there is scatter of radiation, and 50% of the cases, even in these cases, the ovarian hormonal function is lost. Okay, so whenever we are thinking of preserving fertility in cervical cancer, our aim is to preserve both uterine and the ovarian function. So if we plan to preserve the ovaries, so the ovary will have ovarian endocrine function. So surgical excision of a disease preserving the ovary, as I said, in radical hysterectomy in young women, you can preserve the ovaries. As we say, if you're planning to do chemoradiation, then you transplant the uterus in a different location. But the problem is that with 50% of the cases, the ovarian function will still be lost. So the other option is taking the ovarian cortex out and implanting it in other parts of the body, like the hand, the feet, somewhere else, which is far, far away from the radiation field. So this is the endocrine function I'm talking about. But we have to think about the reproductive function if I'm thinking of fertility preservation. So the eggs can come from the woman herself, her own egg. We can collect the eggs and preserve it for future. We can get the eggs, fertilize them, and preserve it as embryos. Or in certain cases, there could be donor eggs. But even with donor eggs, I mean, how feasible it is in this context is very, very far-fetched thought. So next thing is to preserve the uterus. Now, if I'm preserving the uterus, of course, if I can do excise a tumor only and preserve the body of the uterus, then her own uterus remains, but it can be another woman's uterus. This is something new, which I will have, I'll throw some light on in my subsequent presentation, that this uterus can be another woman. So the eggs and the embryos is preserved, and there is another woman who takes the pregnancy in herself in surrogacy. And of course, the scope of transplantation of the uterus is also increasing. So let us look at the literature on techniques of fertility preservation. We know in very small tumors, we can do large loop excision of a transformation zone or a cone biopsy. And if it is stage 1A1 disease, when LVSI is negative, and we have a very clear, at least a 3 millimeter margin. Now, if you look at the literature, not so long ago, maybe 20 years ago, there were publications about patients who had long follow-up after conization. Laser conization, of course, are not very common nowadays, but there's a nice study which showed no recurrences in a median follow-up of 117 months. The other study from Italy, another 45 months of follow-up, and a subgroup of these patients who had knife cone biopsy, only 30 patients of those. There was no carcinoma during the follow-up, but 3 women had recurrence of CIN. So whatever is seen in all these studies, majority of women will have a failure if the margins were positive. So if you're doing a cone biopsy, either a LEDS or a LEAP or a knife cone or laser cone, the margins should be perfectly negative to have the best results. Now, we all know about Daniel Jargent pioneering the technique of trachelectomy, first published in 1994, although he started the procedure in 1987. And of course, there were very strict criteria. Patients must be of reproductive age, the lesions smaller than 2 centimeters, and there was limited endocervical extension, or there's no evidence of extracervical spread. Those are very strict criteria. And then, of course, a good outcome was seen. Subsequently, Shepard, Lonowska published big series of good number of patients, and the recurrence rate was acceptable. And then, the fertility rate is not clearly mentioned in those. More interestingly, there's a Japanese multi-center study recently published, and they actually calculated the 5-year case-specific survival of 98.6% in ideal candidates. When I say ideal candidates, then again, going back to Dargent's criteria, lesion size less than 2 centimeters, reproductive age patient, and there's no extra cervical spread. So from vaginal radical trachelectomy, people moved on to abdominal radical trachelectomy. And of course, the advantages were people are more used to doing abdominal surgery. So the resection margins were wider. Uterine artery could be spared separately, and there are many other approaches described. Minimal access methods were increasingly used before the LAC trial era, but now, of course, there are restrictions on that. And again, the results are quite encouraging. So there were published reports of satisfactory oncology and fertility outcomes. Okay. Now there are other studies where, of course, there was a high conversion rate of up to 30%, 4% recurrence. But again, those who tried, 75% became pregnant. There was another concept coming up where the tumor size was more than 2 centimeters, whether to give neoadjuvant chemotherapy or not. But since our own Indian study that showed neoadjuvant chemotherapy should not be given for cervical cancer patients, I don't know how much this will be applicable in the modern times. So neoadjuvant chemotherapy followed by radical trachelectomy was a proposal at one stage. Now, this is a study published in 2017, I think, where the pregnancy loss rate at trimester 1 and trimester 2 was about 22.4%. Now, this is a combination of many studies where fertility results were published, and the live birth rate was 66.7%. I'll highlight a more important study. This is study from NESAT from the United States, where they have actually looked into a very large population, more than 3,000 patients who had undergone fertility preserving surgery. And their median follow-up was nearly 40 months. Now, interestingly, although more than 3,000 patients underwent fertility preserving, less than half of them actually tried to conceive. So, and there were more than 1,000 pregnancies. Now, those who had pregnancies, 80% was spontaneous and 20% needed artificial reproduction techniques. So if you look at the denominator as the total number of patients undergoing fertility preservation surgery, 55.4% was the pregnancy rate. And again, if you divide the types of surgery, 65% after after cone or simple trachelectomy, and after radical trachelectomy, it dropped down to 53.6%. And the pregnancy outcomes are better in vaginal trachelectomy compared to the abdominal. Average live birth rate was 67.9%. Again, there are variations depending on the type of surgery that was done. So it was again a cone or simple trachelectomy. 86.4% had live birth, but those who had minimal access surgery for only 56.5% were successful in conceiving and having a live birth. There were a very high preterm delivery rate, that was 31%. And again, the numbers were less in cone or simple trachelectomy, higher after radical trachelectomy. Complication rates were quite acceptable after this type of procedures. Cervical stenosis was found in less than 5% of cases, and pelvic lymphocytes, pelvic inflammatory disease, pelvic abscess, all these were very, very negligible. More importantly is the incidence of cancer recurrence and death. So average cancer recurrence happened in 3.2% of the cases, and less than 1% had cancer-related deaths. And there was no difference between the methods that were used for the treatment. So whether you had done a cone or a radical trachelectomy, the recurrence rate and the death from cancer were actually the same. Of course, the case selection criteria were different, so it's not easy to comment that because the cone and trachelectomy have the same result, so we will replace trachelectomy by a cone biopsy. Anyway, so that's how the treatment can be done. Now, what happens to the fertility? So once you have planned a treatment for the woman for cervical cancer, and if she has got a partner, she married, she can have her eggs removed and fertilized, and the embryo can be cryopreserved for a future use. So if the woman is single, then oocyte cryopreservation is possible. Ovarian cortex preservation has also been tried, but I don't think I'm not an expert on it, but I don't think the outcome was as good. So the cortex can be skipped in cryopreservation or in her own body at a different location. So once you have done that, once we have preserved the embryo or we have preserved the oocyte and fertilized it at a later date, then of course we need a uterus. So surrogacy is an option. And that's again, legally in India now it's possible to have surrogacy, especially in these patients where the uterus is lost or uterus is irretrievable, then surrogacy is possible. But again, the new light in the horizon is uterus transplant. Now, I'm not aware whether uterus transplant has been done for any cancer patient yet, but it is a prospect we are looking at that can happen in the future in these type of cancer patients. So a live birth after uterine transplantation was possible. It was first reported in 2015. The first baby was born in 2014 in a 35-year-old Swedish woman who had Rokitansky syndrome. Her mother, who was 61 years of age, donated her uterus, and a baby boy weighing more than 1.7 kilos was born by cesarean section at 31 weeks. So if you review the literature, probably there are until 2021 there were 80 transplants, uterine transplants worldwide. I'm sure by now there are much more, many more. Transplant has already happened, and of course majority were done in cases of congenital absence of uterus. Now, 76% of these women actually had a successful menstruation, and 40 births have been described in these 80 transplant patients. But if those where the transplant was successful, the cumulative live birth after successful transplant was 80%. And of course, there were a high incidence of preterm births. Now, if I look at the future, all of you will remember Dolly the sheep. That was back in 1997 when the first animal was created as a clone. So if that has happened in 1997, if I'm thinking in the next century, maybe a human clone will develop, and there's a lot of ethical and many other issues that we'll have to resolve before we can think of, okay, there's no uterus, there's no ovary, doesn't matter, we can still create a life. That will probably happen, but I do not know how that's going to happen, how the ethical issues are going to be addressed, and that is something for the future generation to answer. But the possibility is there. The possibility is there that the way the science is progressing in the future, in some times later, we will be able to create life without a uterus, without the ovary. So to conclude my talk, of course, fertility preservation is feasible in early stage small volume cervical cancer as of today. It may be different in the future. Pregnancy rates are excellent for those who try for pregnancy. And of course, the key determining factor in Indian context is that people should be aware that fertility can be preserved in cervical cancer. I feel so sad that many young women with one-sided ovarian malignancy, even borderline ovarian tumor, they undergone a complete hysterectomy and bilateral oophorectomy, depriving them of their femininity and fertility. So the awareness is not there even amongst many gynecologists. So we have to make our gynecologists aware, our patients aware that this is a feasible option in very, very selected cases. And of course, to be able to do it, we need to do an early detection. Early detection, if it's there, then only we can detect it early, small disease, and we can preserve their femininity and fertility. Of course, the future awaits. Next century, we'll have a new generation of doctors who will be creating life. Thank you very much for your attention.
Thank you, Dr. Jaydeep, for your excellent and very informative presentation. First of all, I am thankful to Dr. Bhagyalakshmi and Dr. Rupinder for giving us the opportunity to chair this session. Now, I will request Dr. Rema to conclude this session.
Dr. Jaydeep, as you rightly pointed out, and that was an excellent presentation. And as you rightly pointed out, we do get patients with a little advanced disease. So, what do you think about B2? Should we go for an abdominal radical trachelectomy, or have you tried neoadjuvant? I know that doesn't work. So, what will be your practical approach for a larger tumor, 2 to 4 centimeter tumor?
So there has been some research and publications on neoadjuvant chemotherapy, reducing the disease, and then do reducing the size of the tumor, and then do trachelectomy. If you go by Darjan's criteria, it should be less than 2 centimeter in size. Otherwise, the chances for needing adjuvanted treatment is very high. There's very high chance of more LVSI, more chances of pelvic node involvement, large tumor size, more than 50% of the cervical stroma involved. So they will need adjuvant therapy anyway, and the entire exercise of trying to preserve is gone. So we have to be very, very selective about choosing our patients. And then, of course, if we do in very selective cases, we will be successful. But if we try it in patients where it's not feasible, maybe we should look at other options than trying to do trachelectomy.
Yes, and no compromise on oncology, as you rightly pointed out.
Yes, life comes first,
yeah,
and then femininity, and then fertility. So in that order.
But for all those deserving, that option of fertility preservation should be kept in mind. And thank you, Dr. Jaydeep. That is a very wonderful presentation. And thank you, Agoy, for this opportunity to chair the session.
Yeah.
Over
Thank
to
you, Dr.
Dr.
Rama.
Bhagyan.
But before we end, can I just throw a question? It's not a question, like just a thought, because we get lot of women in advanced stages who would need radiation. So should we actually counsel them for the ovarian transposition and give them some time to meet their reproductive biology or a reproductive endocrinologist? Because we never do that. CS service 3B, we directly send them off to all radiation oncologists. So I think for our younger colleagues who have when patients come to us as younger, because women are now starting careers little late. So I think what is your take on that about ovarian transposition or
So
said yes.
we regularly offer young patients ovarian transposition if patient is going for radiation. If we are planning the patient for surgery, then we do a transposition at the time of our radical hysterectomy anyway. But if they're going for radiation, chemoradiation, then we do a laparoscopic ovarian transposition in the paracolic gutter just below the lower pole of the kidney, and we keep the ovary. But still, if you look at the literature, 50% of these cases, the ovarian function will be lost. So we warn them that yes, we attempted like this, and so far the fertility specialists whom we have spoken to, they would request us not to ask for egg retrieval after transplantation, because it's almost impossible for them to get the eggs out of the ovary in a different location. They would rather take the eggs out before we start treatment, and then reposition the ovary for preservation of the endocrine function. So if you have to get the eggs out, it should be done before we start the treatment and before the transposition of the uterus.
Yeah, thank you. So I think I would you request you to just highlight conditions where you would not advise ovarian preservation. Am I audible?
Yes, sorry, say that again.
Yeah, I'll just request you to highlight some conditions where you will not advise ovarian preservation.
See, there are some relative indications where I'm not advising, like adenocarcinoma of the cervix, where you said you should remove the ovaries. But if you weigh that against adenocarcinoma of the endometrium, in stage 1 disease, we are still offering the woman to preserve their ovaries. I feel, I mean, the evidence is there to support that ovary should be removed in adenocarcinoma of the cervix. But again, if a patient is educated, if you can discuss with them, that the chances of metastasis to the ovary is small. But if you want to take the risk, you can try and preserve. But this the standard recommendation for adenocarcinoma of the cervix, that the ovaries are also removed if I'm doing surgery.
I think with the new classification that we now have of the HPV negative and HPV positive endocervical adenocarcinomas, I think we are having a lot of emerging evidence that in HPV negative ones, which are actually more aggressive, ovarian preservation should not be done. But which are HPV positive, which are a less aggressive variety, we can think about ovarian preservation. I think Rohit, you wanted to tell something?
That's what I mean. Basically, ovarian transposition should definitely be offered in young patients, especially below the age of 40. Even if the family is complete and she does not desire future fertility, at least there is a chance that you can preserve the ovarian function. But as Dr. Bhaumik has rightly said, 1 in 2 ovaries, you will, in spite of transposition, they will still fail. But it at least will save those 50% of ovaries, because primarily the radiation tolerance dose of ovary is very, very less. So even if there is some amount of scatter radiation, the ovaries are expected to fail.
Okay.
And
I think
again,
there are a few questions, sir. Yes, sir. Yes, sir. Please go ahead.
I mean, the evidence to support it's not that robust. It's not a huge, strong evidence to say that whoever is will have to be. There are suggestions, there are recommendations, all the guidelines will say that. But if you look into the evidence, it's not all that robust to say ki you have to remove all the time.
Okay, sir.
Maybe a definite indication would be some unusual histologies, like you said, carcinosarcoma and neuroendocrine
Yes.
cervix would be a definite indication to remove ovaries. Adenocarcinoma, we have to think about HPV independent, maybe a relative indication. There are a few questions. One is about doing simple trachelectomy or conization instead of radical trachelectomy. Probably they are talking about after neoadjuvant chemotherapy.
Yeah, again, the role of neoadjuvant chemotherapy is severely criticized now. It's
Yeah.
still in some areas, but we have our own Indian study going very much against neoadjuvant chemotherapy in
Definitely.
cancer because
Yeah,
many
also,
of these patients are
yeah,
actually upstaged. So while we are thinking
Yeah.
that we're going to reduce the size of a tumor, it's actually getting upstaged, and the survival chances are inferior. We'll wait for the results of the NSCT to radiotherapy, but when I'm thinking of surgery, neoadjuvant chemotherapy is not advisable. There's been a few
Yes,
studies.
simple.
yeah, I think Jaideep, that was an amazing presentation. And as to what Bhagya said about HPV negative, I'm not so sure that it is the standard of care. It's a presumption that if it's an HPV negative, so perhaps we should not preserve ovarian tissue. But I don't think we have any leading evidence as yet. So, but as things go by, then we'll
Yeah,
get to
because the
know. And
classification has just been in place.
yeah,
So
yeah, yeah.
these
So
are
it'll
some of
take
the
a while.
evidences that are coming up, though they are not in the guidelines.
Yeah, anything about AI? Has
Where do you look for
AI
PCP?
progressed?
Yeah, if you're looking for P16 as a surrogate marker for HPV, certain cases of, or it can be in situ hybridization that we can do on the tissue sample to say if it's HPV positive or not. But again, the tests are there, but how robust is that test? There are many issues to answer before we actually say, okay, we will take over.
Yeah, it's a true
Especially
negative.
we'll have to be available in that center
Yeah.
to do that.
Dr. Jaideep, when you talked about NSAT being heavily criticized, I think this is this is one area that is in fertility preservation when the tumor is more than 2 centimeters, that it has been, of course, there is no evidence for it, but it has been advocated and people have found good results. So there are a few
There have been good
indications
case
for
series,
NSAT.
good case series which have shown good result. Yes, of course.
Yeah, for at least for fertility preservation, maybe should not write it off.
No. Should not be written off. That's why I mentioned in my presentation as well that the option is there. There is some case series describing that, but again, you have to make sure that
Explaining the pros and cons and everything else, I think. Yeah.
For the patients who are stage 3B, when we are sending for CTRT, is it safe to offer, because the incidence of ovarian metastasis in early stage is less than 5%. But what is the, we don't have a data how many of the 3Bs will be having ovarian metastasis. So should we be routinely offering them ovarian transposition, especially when they are close to 40 years and all? Is it really safe?
So, first of all, the lymph node metastasis is very important. So our current practice is, if you are doing very rarely we do fertility mastectomy days, but if you do over time and the patient is young, so we'll send the nodes for frozen section. Frozen section positive, there's no point preserving the ovary because that ovary, the chances of metastasis in the ovary becomes high. Okay, and we'll give her menopausal hormone therapy after. There's no contraindication for that. But if I'm trying to, if the nodes are negative and proceeding with a radical hysterectomy, then the transposition can be done.
I'm not asking the patients who are undergoing surgery. Patients who are undergoing surgery are anyways early stage. In an advanced stage, like 2B and 3Bs, where we are sending them, and the patient is very young, is ovarian transposition really safe option for the preservation of only endocrine function?
If the lymph nodes are negative, you mentioned stage 3, that means lymph nodes positive. In stage 2, yes, you can. But if the lymph nodes are involved, then we would prefer not to do the transposition. The lymph node involvement increases the risk of ovarian metastasis, as I understand.
Yeah. So thank you so much. I think in the benefit of time, we move ahead. There are some questions in the chat box, Dr. Bhaumik and Dr. Emma would request you to answer them.
Yeah.
So we move to the next talk, and that will be by Dr. Rohit Ranade. And we have two great persons to chair the session, Dr. Jita Parija, who is the Vice President of AGOI, and Dr. Sapada Desai, who is a consultant at the PD Hinduja Hospital at Mumbai. So request Jita Madam to please introduce our next speaker. Hello.
Am I
Sampath,
audible?
yes,
Am I
madam.
audible?
Yes, yes, madam.
Yes. Can I have the CV of Dr. Rohit?
Yes, madam. It is on the
Okay.
screen.
I'm not getting it. Hello? I think there's a net. Anyway, Dr. Rohit is needs no introduction. I'm having some network problem. Bhagya, I think you can read the CV. Huh. So he is Dr. Rohit Ranade, and he needs no introduction. He's in the Narayana Health Center, Bangalore, the Joint Secretary of AGOI, and he's doing a lot of robotics, and I think they have done a lot of sentinel node also. So I think you'll be hearing from him about a sentinel node in cervical cancer. Rohit.
Thank you. Thank you, madam. Can I just share my screen?
Yes, sir.
Yeah. Is my screen visible?
Yes.
Yes, yes.
Please put it on full screen.
Yeah, sure. Yeah, so we will. So thanks again, Agoy, Dr. Bhagyalakshmi, and for organizing this. January is the month of cervical cancer awareness, and it's good to be in a meeting where a little uncommon, but I think important topics are discussed. So I will be talking about sentinel lymph node in cervical cancer. I think sentinel node is probably evolved as a treatment strategy in breast cancer, in vulval cancer, and in endometrial cancer as well. It is more or less established as the standard of care. We have some emerging role in rectal cancers as well. And so naturally, we will see if there is a good role for sentinel lymph node dissection in cervical cancer. So I'm not able to move this. Yeah. So this is basically what I'll be discussing. First is why do we need sentinel lymph node dissection, and then what is the technique of sentinel lymph node dissection, and then the lymphatic drainage pathways, and then we will look at what is the evidence, which is the most important thing, whether we can offer it to our patients or not. So why sentinel lymph node dissection? This is a fantastic site for a surgeon. All of us want to do surgeries like this, remove all the nodes from the template which is there, and it's quite a surgical pleasure. But then when we see patients like this, that is when you literally struggle. So these all patients, especially early stage patients, they get cured of cancer, but they have horrible side effects like this. And mind you, once the lymphedema sets in, there is very little that you can do. There are a lot of measures which have been tried, but again, the benefits are not very great. So essentially, sentinel lymph node dissection, the main and the most important goal of a sentinel lymph node dissection is minimizing morbidity of an extensive lymph node dissection, because we know that nowhere in any type of cancer in the body has a removal of non-enlarged nodes or non-involved nodes shown to have survival advantage. Again, it is expected to shorten the surgical time. Now, it is expected that we do a more accurate staging, because for a normal lymph nodes, you will not be doing an ultra staging. In a sentinel lymph node dissection, you will be doing ultra staging. And also, as we have seen more extensively in the endometrial cancer domain, that we get nodes outside the routine lymphadenectomy boundaries, which would have been missed if you did just a standard lymph node dissection, thus allowing for better selection for or adjuvant therapy. So coming to the sentinel lymph node technical details. First is what do you use? What is the agent that you use when you are doing a sentinel lymph node dissection? So essentially there are three methods. One is the colorimetric method, then the radionuclear method, and then the most popular or the one which is maximally used probably is the near infrared method. Now, calorimetric method involved visual detection of lymph channels and nodes using the colored white light. It was least complex. They tried isosulfan blue, but it was a little expensive. It has been FDA approved. There was 1.1% risk of allergic reaction. At least, frankly speaking, I have never used isosulfan blue. Methylene blue is something which is more commonly used, but it is still an off-label use. There are some case reports of paradoxical methemoglobinemia and serotonin syndrome which have occurred with that. Now, radiocolloid, the radionuclear method uses a radiocolloid technetium-99 and detecting an intraoperative nuclear imaging and intraoperative gamma cameras. There are short and long protocols. You can do a preoperative lymphoscintigraphy or you do a SPECT CT, and you have to have an intraoperative gamma probe. So essentially, this is a little costly method. Primarily, you need a functional nuclear medicine department. You need a gamma camera in your department, and you need more expertise also to handle the gamma camera. So that is where a near infrared method, which uses an ICG, the indigo cyanine dye, which emits a fluorescent signal in the near infrared range, has come into practice. And also, what it has shown is, as we are doing more and more minimal access, not just in cervical cancers, but in other cancer subsites as well, the ICG has actually found its use because one is it is easy to integrate into your practice, doesn't require a nuclear medicine department, doesn't require a separate gamma camera. Most of the laparoscopic systems these days and the robotic system also have the near infrared cameras. And then in addition to that, for open surgeries and for surface tumors, there are near infrared cameras also which are available in the market. So this is essentially how the dye looks like. This is the vision in the camera. This vision is not from cervical cancer. It is from a vulval cancer, the resected node specimen. You can see how the sentinel node looks like. So this is how the ICG is taken up, and this is the near infrared vision which will give you this role. Now, second, coming to the most important thing. Now, essentially, when you start doing a sentinel node program, you have to make sure that you have ultra staging. Now, typically, sort of a histological imaging of a sentinel node involves a single HNE section. Ultra staging, that you have to utilize enhanced pathological techniques, and you have to take deeper serial sections and IHC stains as well. So this is basically how the ultra staging is done, either a broadleaf slicing or a longitudinal slicing. So essentially, we need not go into the technical details of ultra staging, but whatever it is, you need to know that the pathologist has much more work when you are doing a sentinel node dissection as compared to when you are not doing a sentinel node dissection. So the slices are more smaller, primarily because you need to detect micrometastasis as well as you need to detect ITCs. In today's world, if there are ITC clusters, they are also taken as positive. So that is why detection of micromets and ITC clusters is also important when you are doing a sentinel lymph node dissection in any cancer. So this is just the algorithm of what you will do. Now, coming to the injection sites, these are basically more applicable for endometrial cancers, but for cervix, it is only the cervix is easily accessible. So the cervical site is the most commonly site used, and that is the one which is used in all the trials. There is not much evidence for other sites, especially for cervical cancers. All of that evidence is for the endometrial cancer. In endometrial cancer also, now we know that injection into the cervix is safest, and it is more likely to detect the nodes. So now there is something which is important, is the concept of sentinel lymph node algorithm, which should be followed. Now, essentially, when you inject the dye and you wait for some time and you allow the dye to pick up by any method that you're using, either a combination of methylene blue and technetium camera, technetium-99 with a gamma probe, or you're using the ICG induced mode, you have to excise all the mapped sentinel lymph nodes, and you have to submit everything for ultra staging if they are negative on HNE. In addition to that, all the enlarged nodes and all the suspicious nodes, they must be removed irrespective of mapping. Even if your sentinel node doesn't pick it up, you have to remove them, primarily because sometimes when the nodes are enlarged, their lymphatic channels might be blocked and the sentinel node may not pick up those nodes. Also, it's important that if there is no mapping on that side, if for example, if left side you're doing, the left side is absolutely clean and you don't see any node light up, you have to do a site specific lymph node dissection should be done. So that is something which is important. This is just a description of the lymphatic drainage pathways. The upper paracervical pathway usually runs along the uterine artery and drains to the medial external and the obturator lymph node, while the lower cervical pathway drains along the sacrouterine ligament and in the presacral area. So both these areas you should be scanned when you are doing a sentinel lymph node dissection. We have seen sentinel nodes as high as para-aortic, presacral, precaval, and sacral group as well. This is just a diagrammatic showing the drainage pathways for the cervix. Now, coming to the most important thing, is there any evidence to offer sentinel lymph node in cervical cancer? So if you look at the NCCN guidelines, there is some data to suggest that for 1A tumors with LVSI, with stage 1B1 and 1B2 and 1B2, this is the new 1B2, and for certain subset of 2A1, though I am not sure if you can offer it at this point of time to 2A1 patients, you can offer sentinel node dissection because 2A1 was included in some of the trials. Now, this is just the injection sites which are shown. So you can either inject at 3 o'clock and 9 o'clock, or you can do it as a 4-quadrant procedure, or in this way as well. Also, the most common sites where the sentinel node is detected are medial to the external iliac vein, ventral to the hypogastric, that is to the internal iliac artery, and major part is the obturator nerve. As compared to endometrial cancer, from whatever data we have, the para-aortic sentinel lymph node detection is very, very rare in cervical cancer as compared to endometrial cancer. This is just the diagram showing the sentinel node algorithm, what you have to do, which I have already explained. Now, coming to the most important thing, is there any evidence to offer sentinel lymph node dissection to our patients in practice? So essentially, the evidence comes most of the times from the SENTI trials. Reading all the trial, I got a lot of sentimental because I still don't know which is what. So essentially, these are the SENTI group of trials. So the Cervical 1, 2, and 3. The Cervical 1 was the first trial which was done, which established the diagnostic accuracy of sentinel lymph node dissection. The Cervical 2 was mainly on the lymphatic complications. The Centix was more on the oncological outcome, where sentinel lymph node biopsy is non-inferior to a pelvic lymph node dissection. The Centirect is looking at the diagnostic accuracy of sentinel lymph node biopsy in tumors more than 2 centimeter, and the Cervical 3 is actually looking at the long-term oncological outcome. So this is Cervical 1, which is probably the most read out paper, which was published mainly from France, and the main aim was to detect the sensitivity and the negative predictive value of a sentinel lymph node biopsy. And it mainly took 1A1 patients with lymphovascular invasion and stage 1B1 patients. Essentially, this were the old classification because the new classification had not come, and this was a prospective cohort study mainly at centers in France. This is just the trial diagram. So the dye used in this case was the technetium 99 and a methylene blue also. So they used a combination of both technetium 99 as well as a methylene blue. All patients underwent a pelvic lymph node dissection. There was ultra staging which was done, and enrolled patients were about 145. Now, in this case, majority of the patients underwent a minimal access surgery, and all surgeons had experience of performing sentinel lymph node dissections from 1 to 8 years. So the detection rate was as high as 97%, and sensitivity was as high as 92. But what is most important is the negative predictive value was very, very high of 98.2. This is as very similar to what the FIRES trial has shown. So this trial concluded that in patients with early cervical cancer, the sentinel lymph node biopsy is a sensitive method for detecting lymph node involvement. And when combined labeling is used for sentinel lymph node dissection, the presence of a sentinel lymph node indicates an absence. So it was the negative predictive value was quite good, and it did not miss any positive lymph nodes on the sentinel node. Now, this is another study which looked at actually the diagnostic value of an intraoperative examination of sentinel lymph node dissection, whether frozen section had any value for sentinel node as well. So about 75% patients underwent an intraoperative examination, and there were 17 false negative sentinel lymph nodes, 4 had macrometastasis, and 4 had micrometastasis, and 9 had isolated tumor cells, and the sensitivity was just 20%. So in a situation where you are doing a sentinel node, probably frozen section is not a mode to examine. You have to subject the nodes for ultra staging. Don't base your treatment on the basis of frozen section only. So this was the second trial, the Cervical 2 study, which mainly looked at comparing the morbidity of a sentinel lymph node biopsy with the pelvic lymph node dissection. Again, the inclusion criteria were same, and tumors more than 4 centimeter were excluded. It was basically a multicentric prospective trial, mainly in France, and between 2009 to 2012. This is just the trial diagram. I will just skip this. Now, the primary endpoint was the frequency of patients having one or more early lymphatic complications in 6 months. And the secondary endpoint was obviously the quality of life and oncological assessment as well. Now, the proportion of patients with any lymphatic morbidity at 6 months was significantly lower in the sentinel lymph node group as compared to the pelvic lymph node group. There were 8 recurrences which were observed in the sentinel lymph node group versus 5 in the pelvic lymph node, and a 3-year recurrence survival of 92 and 94%, which was corresponding to the pelvic lymph node or the survival results of the LAC trial, the open group as well. So by doing sentinel lymph node dissection, we were not harming patients, and also it was definitely associated with a lower rate of early lymph related complications. So the oncological safety will be studied in Cervical 3, which is still awaited. So then in 2021, this is what was published, the 4-year follow-up results of the Cervical 2, the long-term results. And in the long-term results also, you can see that the DFS in both the sentinel lymph node biopsy group, the overall survival is same. So probably doing sentinel lymph node dissection, you were not harming patients in this as per the trial. So then came the Sentirect trial, which basically investigated the accuracy of a sentinel lymph node mapping, and FDG PET was also used. This was mainly in tumors more than 2 centimeter, and women with tumors which were more than 2 centimeter, they underwent a complete lymphadenectomy and removal of all the nodes which were picked up in PET scan. And about 103 patients were analyzed, and the negative predictive value of the sentinel lymph node dissection was quite high, up to 98%, comparable with historic. And so the sentinel lymph node mapping is an adequate procedure for tumors which are less than 2 centimeter. In more than 2 centimeter also, it is quite sensitive, but you have to adhere to a sentinel lymph node logarithm. And till oncological safety is concerned, they said that you have to do a full pelvic lymph node dissection when tumors are more than 2 centimeter. Now, this is the Cervical 3 study. The results are still awaited. The primary objective was to compare DFS and the quality of life. Secondary objective was also outcome of patients with ITC and micrometastasis, and there was also patients with nodal involvement, which were to be followed in a 4-year cohort, in a separate cohort. The median follow-up of 4 years, and the results are still awaited. And this is another study which is still, the results are awaited, the Centix study, which is which is mainly looking at recurrence rate at 24 months and the prevalence of lower, what is the side effects of that, with the hypothesis that probably sentinel lymph node dissection is inferior to treatment and systematic as compared to a pelvic lymph node dissection. So this is what is the evidence is. Before I conclude, I would say that you can offer it to patients which are less than 2 centimeter now, but again, you need to validate your own study, your own results. First, at least about some patients, you have to do a full pelvic lymph node dissection as well as a sentinel node dissection, and you have to see if you are, how much is your sentinel detection rate and how many nodes are you missing. After that, probably less than 2 centimeters, you can offer it to your patients. But more than that, I think you still need to wait for results. I don't know if you can offer it at this point of time to 2A1 tumors, but at least for the others, you can offer it. Thank you.
Thank you, Rohit. Excellent talk. Very informative also. I had a question. Unlike that of endometrial cancer, where we say frozen section is not required for sentinel lymph node, but in cervical cancers, don't you think so? At least in the patient who has got a macrometastasis, will it not change our treatment decisions if you do the frozen section? Though the Cervical trial did not include the frozen section, but doing it, if it comes positive, then we can abandon the surgery at that moment and send the patient for CTRT.
Yeah, ideally it is a right. Ideally it is the right way. I mean, if we can detect something on frozen section, we will avoid an unnecessary radical hysterectomy. But it just said that when the trial was done, there were a lot of micrometastasis. See, macrometastasis, I think most of the good centers with good frozen section expertise will detect. But it is the question of micrometastasis and the ITCs, which are likely to be missed on frozen section. And probably frozen section is an extra expense in the private sector as well as probably in the Western world. And that could be one reason why they have not recommended using frozen section. But practically, yes, in the ideal world, I think frozen section, if you can use it, and the problem is it will be very difficult to do an ultra staging in a frozen section. So that would practically have limited implications.
Can I say something?
Yes, please.
Yeah. So it was an excellent talk, Rohit. You did cover it completely, but not much of ICG use I see, except in the last trial, which we're still awaiting
Yes.
results. But one thing, Sampada, if you talk about when we talk about sentinel nodes, we talk about ultra staging. We don't talk about frozen section. So we have to go with the idea that you've achieved that competence of doing sentinel nodes and after 30 or 40, and then you abandon doing the pelvic lymphadenectomy part and you wait for the ultra staging. So that's the way it goes. So we don't do, at least it is not recommended to do ultra staging for sentinel nodes at all. You wait for the final histopathology and then you act on it. So basically, sentinel node is a final histopathology. It's not based on frozen section. So if it's frozen section, then you don't call it sentinel nodes. You just send it for frozen section and you act on the basis of frozen section.
So
Right?
hi, Amita here. Nice talk, Rohit. Am I audible?
Okay. Yes.
Yeah.
Okay. So what Sampada was actually asking not to do ultra staging on frozen section. What she was asking, and what many of us actually do routine practice, we send pelvic nodes for histopathology. So we recently actually, have written a trial where we discussed at length with our pathologist. So it was decided that lymph node, sentinel node, we will bisect and we'll keep one half for ultra staging, and another half we can do routine frozen on lymph node. Because as Anpada pointed out, if nodes are positive on frozen examination, we will abandon the procedure. So I don't think she meant that you should do ultra staging on frozen section. The question was, as we routinely do.
No, she was talking about frozen section for sentinel node, right?
So frozen section, because some of us still practice that frozen on lymph node, pelvic lymph nodes in cervical cancer patient. And if that is the practice, we many times send all nodes, but we can send sentinel node. And what has to be done to, inform pathologists in frozen section that this is for sentinel node, so that they preserve one half of the node for ultra staging and another half can undergo routine frozen section. And that's what we have written in our project.
That's what you all do it's a study protocol, or you do it routinely?
Yeah, it's a study protocol. We still don't routinely practice frozen section in cervix.
Right.
Yeah, I think the BGCS, ESGO, everyone recommends that you do the lymphadenectomy first, send it for frozen, and then proceed with the hysterectomy.
Yes,
that's right. So if that is the recommendation, So instead of sending all nodes, we send frozen node and the sentinel node, and the definition of sentinel is any blue, green, or
yes. So that becomes simpler for the pathologist also.
Any enlarged node, regardless of a dioptic.
And
Amita, are
Rohit,
you doing ultra staging?
Yeah.
Is somebody talking?
And the other point is just to mention that we have actually ICG system for open surgery also.
Yes.
We do.
Yeah, so there is,
Yes, we are
yes.
doing ultra staging on final,
Ultra staging, yeah.
on routine H&E, then.
Okay.
Another thing, Rohit, when you said that it's more work for the pathologist, I think it's less work for the pathologist because they are going to sample 1 or 2 lymph nodes extensively. Whereas if you send it for pelvic lymphadenectomy, it's 18 to 20 or 22 lymph nodes that they have to. So sentinel node, the other way
Center is
around,
less work.
it's less
I think
work.
probably it's always a new thing, which is it's a difficult to probably enforce it in any system. They are used to seeing all these nodes and to ask them to do. I think ultra staging is a technically a challenging thing. I mean, not a challenging thing, but it's technically sort of a new technique for, not just for the pathologist, because see, the sectioning is done by the technician, by the histopathology lab technician. So there it's like a new skill for them probably. That's
Yeah,
what was
understand.
told to me.
Only a few nodes.
Yes.
One or
If you
two
do,
nodes.
it's not a good idea to wait for the ultra staging report to come and then proceed, I think. No.
No,
But
that is not
if
feasible.
that's
In frozen, it is not
established,
feasible.
and if it's the
think
if
we
it's
have
established, then you
confusing
will
the
wait for the ultra
issue.
staging.
No, so we are confusing the issue. The message should be clear. Ultra staging is done only on final histology.
Yeah, right.
If frozen has to be done, you bisect the lymph node. One half is preserved for final ultra staging and everything, and other half is seen in routine the way they do routine frozen section.
Right.
Yes. Okay. I think Sampada, could you take some questions if they're there?
Yeah.
Yeah, I think there's some question. Has AI been used with SLNB? Studying the uptake could correlate with involvement. Rohit, would you like to comment on this? AI and SLNB?
I am not aware of any AI associated algorithm being developed for
And the
detection
other
of.
point here is it's interesting thought, but uptake doesn't mean malignancy. Uptake means
Yes,
first
yes.
lymphatic channel draining to a lymph node. That's all. It is actually most of the time nodes are negative. So uptake doesn't. I mean, uptake. What is it says that uptake could correlate with malignancy or number of cells. That's not the point. Uptake means that does that drain.
It's just the
Detection of the first detection of the node, not meds.
No, it could also possibly depend on your case selection also. How stringent is your case selection? If you do imaging modalities like MRI, if there are any enlarged nodes in that, if you do FNA again. So you are like sort of filtering a lot of patients out.
No, but it's not like PET CT where you pick up radioactivity. It's not like, it's just dye going to that particular node. And,
Yeah. So I think
It's
there
like
are
a sentry waiting at the gate for the first enemy to attack. And if you pick it up.
Right.
Sampada, would you like to close the session?
Yeah. Thank you, Rohit, for the excellent presentation. It was very informative too.
Okay, so if there are any questions, please answer them. Okay, so we go to the next session. So that's a very interesting session on cervical adenocarcinomas. So we have two moderators. I request Dr. Ashok to invite your panelists, please, and experts.
Audible? Am I
Yes.
audible, ma'am? Yeah.
Yes, yes.
So can I share my screen? Can I share my screen?
Yeah, please share. I think you can.
Can't hear you, Ashok.
Yeah.
Yeah, share screen is on the bottom of your screen.
Yeah.
And a green button. Yes.
Not showing. Is my screen visible?
Yeah, yes.
Visible.
So, good evening, one and all. So, at the outset, I am thankful to Dr. Bhagilakshmi and Dr. Rupinder for giving me the opportunity to moderate the session, that is adenocarcinoma of cervix and enterogen integrated. So, today we have our experts, Dr. Shalini Rajaram, to the HOD of KIMS Rishikesh, and Dr. Amita Maheshwari, the past president of AGOI, HOD, Tata Memorial Hospital. And with me is the most beautiful, most talented, and helpful person, Dr. Bindia, none other than Dr. Bindia, who is my co-moderator. And our experts for today, the expert panelists for today, Dr. Vishwajit, who is the associate professor from Tata Memorial, Dr. Ritu Bhandaria from Command Hospital, Kolkata, and Dr. Upachna, the consultant gynecologist from Vibarua, Dr. Nisha Singh from KGM, professor and unit head, Dr. S. Padma, the consultant gyne-oncologist from Madurai, and Dr. Shruti Bhatia, who is the senior consultant and head of gyne-oncology from Axel Cancer Hospital, Delhi. So, to start with, cervical adenocarcinoma has been increasing its incidence prevalence worldwide despite the decrease of squamous cell carcinoma. It comprises of 10 to 25% of all cervical malignancy in developed world. It has a greater propensity to lymph node met, ovarian, and distant met. Current guidelines do not distinguish different strategies in management for squamous cell carcinoma and adenocarcinoma. Adenocarcinoma cervix is considered related with radio-resistant and chemo-resistant, and its worse prognosis is compared to the squamous cell carcinoma. Non-HPV associated adenocarcinoma that, as per IECC 2017, are associated with worse survival due to bad prognostic parameter like LVSI positivity, lymph node beds, and Silva-3 pattern type. That will be discussed in our during discussion. So, in order to conquer the disease, new strategy of development of new agents must be mandatory. So, there is lots of confusion in the dealing with cases because due to this paucity of literature, most of the retrospective studies, very less prospective studies, and these prospective studies are totally jumbled. It's nothing like only focusing on endometrial adenocarcinoma only. So that's why maybe we will have our panelists at the end of the session, we can have some clarity on adenocarcinoma. So coming to my case, this is a 53 years para for L4 with a history of contact bleeding 3 episodes in last 3 months and purulent discharge for vagina for 1 month. First speculum shows cervix is hypertrophied and unhealthy. For vaginal examination is uterus 12 weeks, size, sub-barrel set cervix. For rectal examination, bilateral parameter supple and rectal mucosa free. And she came with multiple points biopsy taken outside with the SP report of cervicitis. Again, she continued post-menopausal bleeding since biopsy and ultrasound. She has had an ultrasound report with pyometer and endocervical growth of 5 to 6 centimeters sonography. So with this, we did diagnostic hysteroscopy and biopsy, and we found endocervix is full of growth and difficult to visualize the cavity. Both ostia are not seen, and we drained the pyometer around 200 ml of purulent fluid drained out, and patient was to septicemia and was admitted in ICU. Remained in the ICU for more than 1 month. He recovered and again referred to us. So by that time, not moving. My slide is not moving. Yes, patient come back to us with the XP report of adenocarcinoma cervix grade 2, XPV 1618 positive, ER and PR negative. Again, you clinically evaluated that patient after 1 month with ballooning of cervix. Growth is around 6 to 7 centimeters, involving the lower uterine segment and both parameter field. So here stays clinically stage 1B3 as per FIGO 2018. So with this, my question, I will start from Dr. Vishwajit. So how often you come across adenocarcinoma cervix in your clinical practice? Or at a, you are working in a Apex Institute. So how common is adenocarcinoma cervix? So Dr. Vishwajit. Dr. Vishwajit?
Hello.
Can you hear me?
Yeah, I can hear you. Thank you, Dr. Ashok. At the outset, I would like to thank Inder and the listener for the opportunity. If you tell me how common I come across exact data, I have to see our PMC. But to search literature, it's 15 to 20%. You can remember 15 to 20% of all cancers of cervix are adenocarcinomas, and 15 to 20% of all of them are HPV independent. So 15 to 20% rule you can remember for the students.
All are HPV independent.
Yes, 15 to 20% are HPV independent.
Yeah.
And 15 to 20% are adenocarcinoma.
Yeah. Good, very good. So if you just analyze the various literatures, you will find over the last few decades there is so many rise of incidence of adenocarcinoma, and at the same time there is a decrease in incidence of squamous cell carcinoma. to Dr. Gitu, can you explain what are the probable causes of the rise of incidence of adenocarcinoma?
It's probably because of the HPV vaccination. So the HPV associated malignancies are reducing and the HPV independent ones are rising. I mean, that can be only logical reason which I can think of.
Anything else? Any defect in the screening? So can you think that the screening cytology-based screening is it effective to detect the adenocarcinoma precursor cells compared to squamous cells? Because most of the actually in our paramedics that do the screening strategy in peripheral area, they are very well. They can detect this squamous variety, but it's not possible on their part to detect this glandular precursors. Is it because it may be because? What do you think?
Possible, if you use the cytobrush correctly with the liquid-based cytology, it is likely to pick up the endocervical component better than a conventional IS spatula. That could again be a reason.
And do you think that by implementing HPV screening, you can have a more detection in adenocarcinoma from adenocarcinoma precursors? By
Sure.
HPV?
Sure. All the HPV positive patients, you would put them on a colposcopic screening. So yes, you're likely to pick up better because colposcopy is likely to pick up better endocervical lesions. That all these factors could be leading to increased diagnosis of adenocarcinoma. I'm not sure if the incidence is rising. Probably we are diagnosing more.
Yeah. So let's hear from one of our experts, Dr. Amita ma'am. Are you there? Amita ma'am? Dr. Shalini ma'am, are you there?
Yeah, I'm there. What's the
So,
question, Dr.
that's the
Ashok?
question what may be the probable causes of the rise of incidence of adenocarcinoma in over the last few decades?
I think because not in India, probably this is Western statistics. I don't think these are Indian statistics.
We don't have Indian data.
Probably the rise is because is relative because HPV associated cancers have decreased because of widespread vaccination.
Okay.
So vaccination began something maybe in 2007 or so, but I believe that may be the reason that we are able to screen better for SCC, and vaccination probably is the cause, and it will be relative. I'm not too sure why. And in India, we still see majority are squamous cell carcinoma of the cervix. We don't see so many adenocarcinomas even now. Maybe 90%, more than 90 would be squamous cell, and 5 to 10% would be adeno.
So is there any difference?
So ours is around, I think, 15 to 20% adenocarcinomas. One reason, of course, apart from around 15 to 20%. So apart from what Dr. Shalini and you all have discussed, I think pathological skills and characterization and realization that adenocarcinoma is a separate this thing is also has contributed to the increased number in adenocarcinomas. I mean, that's how I feel.
So is there any differences on efficacy of HPV vaccine when dealing with this squamous cell carcinoma and adenocarcinoma?
No, I don't think there is any difference, but anything which is HPV associated is equally efficacious or otherwise. But because there are more adenocarcinoma which are HPV independent compared to squamous cell carcinomas. So if HPV related cancers are eliminated, proportionately you will see more HPV independent cancers. It's
so there is rise of more rise of HPV independent adenocarcinoma.
Apparent, right? It would be apparent.
So this is a relative rise.
Relative, yes.
And that will be for adenocarcinoma, not so much for squamous cell carcinoma.
Yeah. So Dr. Upashana, are you there?
Yes, thank you.
Yeah, sure. What do you think? What are the common risk factors for adenocarcinoma? Sorry.
Am I audible?
Yeah. Very well.
Thank you for the question. Dr. Vishwajit had already said that HPV-associated adenocarcinoma is constitutes the majority of adenocarcinoma of the cervix, around 85%. So in this group of patients, all the risk factors which are associated with linked to the persistence of HPV, for example, young age of intercourse, multiparity, lower socioeconomic status, immunosuppressions, and so on. Other risk factors, plus additionally, we have got our relatively increased risk with OCPs that has been documented. But then we have another group of patients, the 15% patients, HPV independent, even though they are less in number, gastric carcinoma is one of the most common in HPV independent gastric varieties, one of the most common, and there this can be related to some genetic syndrome. Jaeger syndrome is
syndrome, yeah.
associated with it, plus the precursor lesion. It can be associated with precursors of atypical lobular endocervical glandular hyperplasia or atypical gastric metaplasia. So these can be associated, and sometimes
which genotype is more associated among
pardon?
all HPV? Which genotype of
Genotype.
HPV is more? Yeah, yeah.
Like
16,
squamous cell
18.
carcinoma is more associated. However, it can also be associated 16 and 45. So they are present, but 18 is more prevalent.
Yeah, yeah. So next, what are the reasons? Because it is very difficult to diagnose most of the time, because growth is involving the endocervix most of the time and lower influence segment. And the differential diagnosis, endocervical adenocarcinoma with uterine extension with endometrial cancer with endocervical extension. Both have a different strategy of management. So we need to know what exactly, where is the epicenter. So applying our clinical knowledge, imaging, pathology, and ISC, I think we may able to reach at a diagnosis. So to Dr. Nisa, so what are the dilemmas in diagnosis for adenocarcinoma solving? Dr. Nisha?
Yeah, thank you, Dr. Ashok, and thanks to the AGOI team for involving me here. So as far as this diagnosis of adenocarcinoma, why it is difficult is because first thing is it's not in the back of your mind. So when you are doing, your patient is coming with some symptoms, you are looking at the cervix and not looking directly, we cannot see directly into the endocervical canal. And the only method that remains then by naked eye examination or when we are doing so an endocervical sampling, which many times may be missed simultaneously. If somebody really thinks that it is a balloon cervix and looks at it and does an endocervical curettage, then only it will be picked up. That's one. Even in the cytology, the glandular cell evaluation, by the cytopathologist may be sometimes missed, or if it is present, then also with the endocervical curettage, it may or may not be clearly visible. So in the early stage disease or in the glandular lesions which are pre-invasive, mostly it will come up only when there is a cone diagnosis or a leap is done. That is the problem. So one is that people don't think about it, looking only at the cervix, ectocervix, not evaluating the endocervix. And second, also our technical problems of detecting it in the early, in the pre-invasive and the early cancers, which may be difficult. So these are the problems that happen.
Yeah. So as a clinician, we need to be more vigilant in case of any suspicion when we're dealing with a barrel subservice. So we should be more, having more vigilant. Okay.
Yeah.
And okay, yeah.
I
go
want
ahead.
to just say something about the previous question that was there, that why it has. I personally have a feeling that these data are coming from the Western world, and they have reduced the squamous cell carcinoma in particular because of the screening methods and treating the pre-invasive cancers, where the pre-invasive lesions, because mostly it was cytology being used initially.
Yeah. That we are mentioning.
So that is the reason that squamous has reduced and relatively the survival. It's not the HPV vaccination. And if we see just now in the last question, you heard that among adenocarcinoma also 85% are HPV related. So it's with the HPV being used as the method of screening, maybe we will have, both detected earlier. But with the cytology previously, or if we think about the via and all, we will not be able to pick up the endocervical
precursor.
That is what probably I feel is the reason.
Yeah. So we move ahead. So how to differentiate between endocervical and endometrial cancer on the basis of pathology and ISC? This is a question to Dr. S. Padma. Padma, ma'am.
Yeah, I'm here. Thank you, Dr. Ashok, and I thank Bhagya and Agoy for the opportunity. Basically, endocervical adenocarcinoma most of the times is HPV related, and endometrial cancers are of a different pathology by their own. Usually, it is because of hyperestrogenism. So that is where the basic pathology lies there. And when we have to differentiate between two, see, from the cervix can extend into the lower uterine segment, or lesion in the endometrium can extend down into the endocervical canal. So that is where the problem happens. If it is primarily an endocervical growth, then the associated features of HPV changes will be there. Associated adenocarcinoma in situ changes can be noticed. Whereas in a patient with endometrium extending down into the cervix, then the features of endometrial pathology like hyperplasia and other associated stromal metaplasias, etc., is seen. But the most important differentiating factor in clinical practice will be the IHC profile. While adenocarcinoma of the cervix usually is HPV related, and so it picks up P16 positive in IHC. And the other thing is the endometrial carcinoma are ER/PR positive and Wymantin positive. And CEA positive is usually seen with non-HPV related cancers.
Yes.
And of course, when we do a HPV DNA testing, if it is positive, then we know for sure it is an endocervical one. And if it is the other way around, it is the endometrium.
Also, if you go for ISC, also P16 may be patchy positive in endometrial can form variety, maybe a serous variety and clear color variety, but it is patchy variety. Where it is in endocervical origin, it is a block type or it is diffusely positive.
Yeah.
So
can I ask one question, Ashok?
Sure,
Yeah, Dr. Padma, what is the HPV DNA test that they do?
HPV DNA test.
What is it they do? Just the ordinary HPV DNA test you send that we send for?
No, they do the E6, E7 proteins. So because that indicates that
I think the gold standard is HPV in situ hybridization. That's what is the gold standard to distinguish between endocervical and endometrial origin.
Yeah.
HPV-ish, it's called HPV-ish, which is HPV in situ hybridization.
Yeah.
Okay.
Yeah. To distinguish between an endocervical cancer and endometrial, it is HPV in situ hybridization, which is considered today the gold standard.
Thank you, ma'am, for your expert opinion.
Yeah.
So then we did the MRI. We found the infiltrative heterogeneous enhancing endocervical mass of 7 into 5 into 4.5 centimeters with lower uterine segment involvement. Posterior cervical stromal infiltration was there with polypedal funding component with an enlarged necrotic right lateral pelvic wall. So the epicenter was an endocervix. And so with this report, so how will you proceed? So understanding of the natural history of optimal management for adenocarcinoma of the cervix is limited. So this my question to Dr. Shruti: should squamous cell carcinoma and adenocarcinoma be managed differently?
Thank you, Dr. Ashok, and thank you, Dr. Bhagyalakshmi, Dr. Seko, for this opportunity. As Dr. Ashok, you've already said in your first slide, we have seen the difference in behavior of adenocarcinomas and squamous cell carcinomas. They are less radiosensitive and they have a worse prognosis. But unfortunately, the guidelines so far do not differentiate between squamous cell and adeno. So the guidelines are same, and depending upon the stage of the disease, we decide the modality of the treatment. So, so far for this stage, we'll have to go for radiation with concomitant chemotherapy, and stage by stage, there is no difference in treatment, except which we had already discussed in the first session. Dr. Bhaumik had said in HPV independent adenocarcinomas, we do not preserve the ovaries in early cases, but otherwise, rest of the treatment is going to be same for both squamous and adeno.
Yeah. So there is a study in DMC which concludes that the present study demonstrates the patient with adenocarcinoma cervix had poorer overall survival and disease-free survival than patients with squamous cell carcinoma, regardless of treatment with radiotherapy alone or CCRP. So new treatment approaches should be considered for cervical adenocarcinoma. So though the present guidelines do not differentiate, if you go to NCCN 2024, there is no difference in the management of both squamous cell and adenocarcinoma. Maybe in future we have a different guidelines with having a different kind of management for both the two entities.
I think I agree with you the same thing as we had said. As more literature and more knowledge is coming about HPV independent and HPV dependent adenocarcinomas, maybe in future the modality of treatment might vary for both of them.
HPV independent is having very poor prognosis.
Very
It is
poor
worse prognosis than that of HPV.
That's
But
true.
it only constitutes around 10 to 15%.
Yeah, I
Okay.
agree. But then we are already also discussing these tumors are gradually increasing. So maybe
Yeah,
in
yeah.
future, the modality of treatment might change for them.
So my question to Dr. Bishwajit, if you go to NCCN guideline 2024 also, there is a role of in 1B3, there is a role of radical hysterectomy. So I want to ask you here, Dr. Bishwajit, is there any role of primary surgery or is there any role of NSCT followed by surgery? Dr. Bishwajit?
Hello. Yeah.
Yeah.
So for this patient, you see, if you are considering this patient in particular, you have told it's a 7 centimeter growth
Yeah.
shown the MRI, and with a necrotic node and with this stromal invasion, I don't think there is any role of surgery. And as Dr. Shruti told, there's any role of surgery particular to this case. And
there is no role of operant surgery. But do you think that NSCT followed by surgery?
Yeah.
To debulk the disease and then you go ahead with surgery?
No, NACT followed by surgery. You see, we have got studies from our institute,
Yeah,
from
yeah.
India, from Tata, and the URTC as you've highlighted
Yeah,
there.
yeah.
Also. So I think there is evidence that NACT followed by surgery versus concurrent CTRT upfront, it's not superior. NACT is not superior. NACT followed by surgery is not recommended.
Is not superior
yeah.
to CTRT in
Yes.
all the studies.
Yeah.
So to Dr. Gitu, so is there a role of CCRT?
CCRT only has the role here. There is no other treatment. This is the standard of care. So although the response rate to chemo may be lower compared to squamous, but as of now, all the evidence is in favor of CCRT. Regarding the previous question about neoadjuvant chemotherapy, there's an ongoing randomized trial called Contessa trial, which is looking exactly at this subgroup of patients. So maybe in future we may have some answer what role of
But till
chemo.
now there is no role of NSCT followed by surgery.
As of now, outside a clinical trial, I don't think we should be
So
offering.
concurrent CTRT using platinum-containing chemotherapy is the treatment of choice at present for this advanced LACC, that is locally advanced cervical cancer. CCRT results 30 to 50% decrease risk of death compared to RT alone, and CCRT improves both PFS and OS compared to RT. So this is also a study, multi-center study, and which shows that women diagnosed with advanced stage cervical cancer, adenocarcinoma, have poor prognosis. Prospective multi-center trials of platinum-based chemoradiation and other novel therapies are urgently needed in the treatment of this highly lethal disease. So in future, we may have some different kind of management. So to Dr. Upashana, what do you think? What is the role of induction chemotherapy followed by CRT?
Induction chemotherapy by CTRT. Yeah, we recently had the result of the Interlace trial, which had more than 500 patients, but 82% of the patients were squamous cell carcinoma, and they had included patients of 1B3 also. The trial was a positive trial that the CTRT followed by NACT followed by CTRT had showed a better prognosis. But less than 20% of the patients included adenocarcinoma patients. So how are we going to extrapolate this result of this trial? I'm not sure at this stage.
So anyway, for induction chemotherapy followed by CRT, significantly improves PFS and OS in LACC and should be considered as a new standard of care as per this Interlace. So any role of immune checkpoint inhibitors followed by CRT, Dr. Nisha?
This is a relatively new concept about the PD-1 inhibitors. There are some studies that have shown like this keynote study there. Yeah. See, some progression-free survival improvement demonstrated with the combination. You just add it with your CTRT. But then I think more in the metastatic and the recurrent this thing as even in the NCCN they have done.
Not I am about recurrent. There is a different trial. Will come later.
Yeah. So that is what, and so I mean currently we have not put it in the guidelines as a standard of care as a frontline this thing, but this may be the upcoming thing with which it may be added.
This
So
may show the direction in future. May have this
yes.
PD-L1 inhibitor that because it has already proved in in keynote 8 in that PFS improvement has been demonstrated with combination of pembrolizumab and EBRT and concurrent chemotherapy in patients with newly diagnosed high risk and locally advanced cervical cancer.
Absolutely.
So our patients receive CCRT, but unfortunately it came back again 2 months after with a residual lesion of 4 centimeters. So it's very problematic. So how to deal such situation? So my question to Dr. Padma, is there any role of salvage hysterectomy here? He came with a residual disease of 4 centimeters after 2 months.
Yeah. Now, if we are really sure that it is only a central disease, restricted only to the pelvis with no other disease elsewhere, yeah, probably it can be thought of. And
do you think that
yeah,
such a big residual lesion, you should go for surgery? Even after exclusion of all the distant mates by a
yeah, after exclusion. After exclusion,
do you think that you should go for advanced such a big lesion of 4 centimeters?
Yeah, it will, if it is the only lesion, and we can, yeah, it can be thought of. And but especially when there is that is the only lesion and nothing else is there, and so probably we can do a restricted exenteration also if it is possible.
Yeah.
When we are sure that there is no other disease elsewhere, and if there's only disease, and because already the entire treatment has been given for her with CCRT.
Yeah. So adjuvant hysterectomy, though it improves pelvic control, but have no OS benefit and more morbidity. So Dr. Shruti, so what is the role of comprehensive molecular profiling in such recurrent cases or residual?
As we have discussed previously in the keynote study, although they have studied in the early cases, in the metastatic cases, but even in all recurrent cases, we should do a detailed molecular profiling, which should include PD-L1, MSI testing, tumor mutational burden, because we have seen a lot of good evidence of pembrolizumab coming up with in cases of recurrent disease, and also nivolumab is coming up, which can be used in cases of metastatic cases. Dr. Ashok, I'll just add one point to your previous question. Salvage hysterectomy, like we have seen in our clinical practice, is actually very good because it improves local symptoms. A lot of these patients come with a lot of bleeding or discharge. So if we do a salvage hysterectomy, the quality of life improves in these cases, although the surgery is a bit morbid and it has sometimes related with complications, but it overall does help the patient.
Let's have an expert opinion from Dr. Amita. Amita ma'am, are you there? Amita ma'am. Shalini ma'am, are you there?
No, Shalini ma'am has gone, Dr. Ashok.
Dr. Amita? Dr. Bhagyalakshmi, are you there? So regarding adjuvant hysterectomy, so what's that take on? So let's listen from any expert. Anybody can answer.
So can I give my opinion?
Yeah, sure.
So you see, after 2 months of completion of treatment, evaluation for a hysterectomy, salvage hysterectomy, or exenteration actually is not ideal.
Not at
when
all.
you go to the guidelines, you should at least wait for 4 to 6 months. The response to set in, do a biopsy, prove it, then you can go for a salvage hysterectomy. So
definitely.
2 months is not a 2 months. Not a.
So it's a residual disease. It's not a recurrent also. We cannot stamp it as a recurrent.
You have to wait for the. You have to wait for the therapy. You see, radiotherapy and chemotherapy. It's not that you put it, you get the response immediately. You have to wait for at least 4 to 6 months. Like if you see the guidelines also, that is
Suppose
is
Dr. Vishwajit, suppose he comes to you after 6 months with a residual lesion of 4 centimeters. So what do you think? How will be such a
So yes, after 6 months, after 6 months you can do biopsy to find there is active disease. Then what we do is we get referrals from respective hospitals. So we do with the patient.
Then go ahead with some adjuvant hysterectomy.
We examine the patient under anesthesia. You should do a UA. Number one. Prove it that there is disease. And then, if possible, if the parameter is free, you can go for a salvage hysterectomy.
Okay. Thank you. So,
also the guidelines also, Dr. Ashok, in the NCCN guidelines, in the third option as category 3, they have
Yeah,
written
yeah.
after of CCRT, this residual disease salvage is an option.
Yeah. But we are concerned about a big growth of 4 centimeter, who came to us after 2 months with a residual disease of 4 centimeters. So that's the question. So
Padma
it's different from guidelines. So
if it is like an adenocarcinoma, especially if it doesn't respond much to the other things. So as Madam said, exenteration, if it is feasible in those
we can go
settings.
ahead with exenteration. Yeah. So coming back to our question, the previous question, that is all these tests of comprehensive molecular profiling should be FDA approved. We should go for FDA approved after like PDL1 testing, MMR, MSI. So how will you deal such cases, Dr. Padma? Suppose your PDL1 positive and you would have a positive score, you scored it, and then how will you tackle such a situation?
Can anybody else take it up? I'm not very comfortable with that.
Yeah. So you have a good number of regimens in your armamentarium. Starting with first line regimen with PDL1 positive tumor. For PDL1 positive tumors, you can start with pembro plus the carbo plus or minus bevacizumab as per this NCCN 2024. Or you get second line, you can start with everywhere. You can start with the pembro, and with all this testing. After this testing, it comes to positive, you can go start with the PDL1 inhibitors. So coming to this keynote 826, which says that pembrolizumab, when added with platinum-based chemotherapy, with or without bevacizumab, prolongs PFS and OS in present recurrent and metastatic cervical cancer. So our patient has gone to Tata and he received pembrolizumab plus chemotherapy and lost for follow-up. So the last question. So again to Dr. Padma, or anybody can take this question. So what are the prognostic factors on adenocarcinoma cervix?
So as such, adenocarcinoma, they are more, a little resistant disease, both for chemo and radiotherapy. So the diagnosis of adenocarcinoma itself puts a little a setback for the patient. But then what holds good for the squamous cell carcinoma holds good for adenocarcinoma because the treatment is almost similar. And when we go ahead with the surgery, what we are worried about is the stage of the patient. Then when after doing a surgery, we are interested in knowing about the high risk factors and the intermediate risk factors. So if any of the high risk factors are positive, then it becomes more high risk disease. Any evidence of any lateral margins, vaginal positive and lymph node positivity puts them.
So apart from the FIGO test, other LVSI, tumor size more than 4 centimeter, lymph node positivity, and advanced stage 3 like stage 3B and extrauterine extension are considered as a high risk factors for prognostic factors for this adenocarcinoma. And from a Japanese study, that it is though it is a retrospective study of adjuvant RT after radical hysterectomy compared to efficacy for RT in different histologies, and they have proved that the histological type did not affect the outcome, though in stage 1 disease. But in stage 2 disease, adenocarcinoma is significantly worse prognosis than that of squamous cell carcinoma. Among the patients with lymph node involvement, patients with adenocarcinoma exhibit a significantly worse 5-year survival rate compared to those of squamous cell carcinoma. Patients receiving the adjuvant RT and those with adenocarcinoma showed a higher recurrence rate of central recurrence, both pelvic and stomach, than those of squamous cell carcinoma. Another study also that reports, though it's a retrospective study, it shows that adenocarcinoma was poorer than that of squamous cell carcinoma significantly. An analysis of prognostic factors that have found LVSI, what I mentioned, stromal invasion and adnexal mets are associated with shorter survival in various multivariate analysis in adenocarcinoma. So with this, we move ahead to the second case. Now go to Dr. Bindia. Dr. Bindia, are you there?
Yeah.
Can start the second case.
Yes, thank you, Dr. Ashok, and thank you, Dr. Bhagyalakshmi, for giving the opportunity. So, Dr. Ashok, you have to move the slides. Yeah, so this patient is a 35 years old, para to life 2 with again blood-based mucoid discharge and heavy menstrual bleeding for 5 months. Her previous cycles were regular, and she also had history of weight loss for 3 months. Next slide. The past history and personal history and family history were not significant. Next slide, Dr. Ashok. So she had investigations done outside for her issues, and an ultrasound was done, which revealed a submucosal fibroid, which is occupying the lower part of the uterine cavity and was also extending into the cervical canal. A CT also was done outside, which revealed queria intramural fibroid with submucosal component. And also there were 2 calcified mesenteric nodes in the left lower abdomen. And the biopsy was also done, which of the endometrium, which revealed a poorly differentiated carcinoma. So with these reports, she was referred to us for further management. So when we examined her, she was quite a thin-built lady with a BMI of 22, and the systemic examination was normal. Next slide. On abdominal examination, also there were no findings. On per speculum examination, the cervix was hypertrophied with an Ebodian cyst, and breast, vagina, and was normal. There was only mucoid discharge. On per vaginum examination, the uterus was bulky, around 8-week size, and the uterus was kind of mobile, and the lower uterine segment seemed to be distended, and the cervix was kind of effaced. And on per rectal examination, also in PVR, the bilateral parametria were free, and there was no nodularity in the pouch of Douglas. So the provisional diagnosis which we had kept after an examination and with the investigation, whatever she had, was that she was a poorly differentiated carcinoma with a query submucous fibroid. So at the OPD only, we did a pap smear. Next slide. So it was the pap smear came out as Aegis, which was and a slide review also was done, which revealed a high-grade carcinoma, and there was no endometrial tissue identified in the biopsies. So with this kind of a picture, Dr. Vishwajit, what is your next line of action? There is a diagnostic dilemma. So what should be done next in this case?
Thank you, Dr. Bindya. So when there is a diagnostic dilemma, I think we have discussed earlier also between endocervical lesion and or a lower uterine segment lesion. So best investigation modality, if you tell me, is the MRI. And second best investigation modality will be the immunohistochemistry on the blocks. The MRI, the sagittal section, you see where is the epicenter of the lesion is. If the epicenter of the lesion is in cervix, usually the lesion is in it's a cervical cancer. And you have already told that it's the histopathology, there is no endometrial tissue identified. So you can do a morphology along with the immunohistochemistry, put the markers, and that will very well tell you exactly. In most of the cases, let's say endocervical origin or of the endometrial origin.
Yes, you're absolutely right, Dr. Vishwajit. So basically, the epicenter of the tumor has to be identified, and MRI is the best modality whenever we have these kind of dilemmas. And a very nice paper had come recently in which they gave the very nice findings about how to differentiate between a cervical and an endometrial cancer whenever there is a confusion. So as they had a very nice pictorial representation also. So whenever in a cervical cancer, it will be a roundish shape, while in an endometrial, which is extending, it will be in an oval shaped manner. And the growth is more horizontal when you have cervix, while it is more longitudinal when it is endometrial. And when you have locoregional spread, there'll be more of parametrial involvement in cervix, while there'll be more prior myometrial invasion when it will be an endometrial cancer. And when we do the contrast, we can see there is also a high degree of there's a higher signal intensity in cervix, while the signal intensity is lower than normal in endometrium. It is more hypervascular on a dynamic contrast enhancement on MRI. And also lymph nodes, more commonly lower parts will be involved in cervix, while in the endometrium there will be more of iliac and the upper part of the lymph nodes may be involved. So to solve the dilemma, MRI was done. So next slide, please, Dr. Ashok. This we repeated in ultrasound. So as you can see in the ultrasound also, this lesion was there in the lower part of uterus, which is extending to the cervical canal. There was no intralesional vascularity, and only peripheral vascularity was present. Next slide, please. So this is the MRI picture, and if you can see, there was this big growth in the cervix, and as rightly said, the epicenter has to be identified. So besides IHC, the epicenter was there in the cervix only, and it was extending into the upper part of the uterus, and there was no extension in the vagina. And you can see very clearly the endometrium is also visualized. It was around 11 millimeters. And if you can see the transverse section, there's no parametrial invasion. That ring of confidence, that hypoechoic ring, is still intact. So there's no parametrial infiltration of the tumor into the surrounding structures. So next slide, please. We also did the tumor markers. It was almost almost quite normal. It was CA1 was 43. Next slide. So because it was agas and all, we also did a colposcopy. The external cervix was normal, sweet score was 5. A high risk HPV testing was done, which was negative. But since there was so much of a dilemma, so what we decided, we repeated the biopsies. So cervical biopsy, ectocervix was fragmented. Endocervical curettage was suggestive of a high-grade carcinoma, probably a clear cell cancer. And an endometrial biopsy was done, which we went high up. The endometrial tissue came out to be normal, and there were only few fragments of the tumor tissue as described in the endocervix. IHC was done as we had discussed in the previous case. P16 was negative, ERPR was negative, and P53 was wild type. Next slide, please. So if you can see the microscopy, we have very clear morphology of clear cells are seen, and we can see the vacuolated cells with the mitotic and the atypical hypochromatic nucleus pushed to the periphery. So these are typical clear cells, and there was no doubt that now we are dealing with a clear cell endocervical adenocarcinoma, and which falls in the category of the HPV negatives. Next slide, please. So we've already discussed, so just for the benefit of some postgraduates who are attending, Dr. Geetu, we can just revisit the entire classification of adenocarcinoma of the cervix. It's just a repetition.
It's a silver classification and gives A, B, C, and describes as a gastric or intestinal or a clear cell variants. Yeah.
Yeah, so basically HPV negative, which we are dealing with, as we discussed earlier, also gastric type is the most common type. And the rest of the other variants are the clear cell, the mesonephric, the adenocarcinoma, and the endometrioid variety. However, ours was the clear cell variety, which we were dealing with. And HPV the dependent types are usually the usual type, and the mucinous variant also is also HPV positive. And next slide, please. Is there a prognostic classification, Dr. Upasana? We don't deal it normally in the HPV independent, but in HPV dependent cervical adenocarcinomas, is there any prognostic classification?
Yes, we are generally nowadays classifying as per the silver classification. A, B, and C. A generally are more common with the HPV associated group. Here there is the destructive type of invasion is absent, or it is minimal, and there is no LVSI. The patients in this group of patients generally they respond better to any treatment. And whereas C refers to the worst kind of invasion, where there is more of destructive invasion, more LVSI, there is a risk of distant metastasis. And this occurs mostly. It is also this pattern is associated with a poor prognosis, and B is generally between both A and B. So this is the classification.
Yeah, absolutely correct. And so the pattern classification is now being used by pathologists also. They do give some report if there's the destructive invasion and expansile variety, or what is the LBSI. So as you rightly said, it is pattern C is the most, it is the one which is the poor prognosis. LBSI is positive and there's higher chances of recurrence. So destructive invasion is more with pattern C. So this is the prognostic classification of the adenocarcinomas. Next slide, please. Dr. Ashok, next slide.
Oh, yeah. I'm trying. It's not moving. Not moving.
Okay.
I'm trying.
Yeah, no problem.
So, not moving.
Okay. It's not moving?
Not moving.
So, okay, let's discuss the management.
Yeah. Now it is.
So, let's discuss the management. Dr. Nisha, what to do further for this?
As per the clinical examination and the MRI that you showed, it was falling into stage 1B3, I believe. Is that right?
Yeah.
There was no parametrial invasion. There was no, lymph node. Although in the initial one you said some lower abdomen, but Later in the MRI, you didn't mention. Yeah.
Not
If it is 1B3, it's like a local stage. As we said initially, that as per the current guidelines, the management protocols as such are not different. So this is a locally, enlarged disease where you can directly go for a CCRT, concurrent chemoradiation, or you can take them up for the radical hysterectomy with the lymph nodes, and then depending upon the you first do the lymph nodes, and depending upon the lymph nodes, if they are positive, then you leave, and if they are negative, you go ahead. But remember that with a clear cell carcinoma, a very poor prognosis disease, and the possibility of lymph node in this thing will be relatively high in this case, as we believe. So probably for this particular patient, one would go for the concurrent chemoradiation here in this case. And although the three options that you have shown through this thing, non-fertility sparing treatment protocol from NCCN, they are there. The third one you were talking about, if for the this thing also, the category 3, where there was a completion, this thing that is there. But by and large, in this case, probably I would go for a concurrent. Yeah.
okay. Okay. So in this case, we were discussing about the role of NACT in squamous. We were discussing in HPV-associated endocervical. Dr. Shruti, any benefits in these kind of tumors of clear cells? In this patient was Paris. She was 35 years old. If suppose she had been younger and she would have wanted some fertility preservation, would you have given a trial of chemotherapy? Any experience with you? If you have any experience with NACT in clear cell or the non-HPV-associated adenocarcinomas? Dr. Shruti, please.
Yeah, sorry. As we have discussed before, NACT so far there is not a standard of care, but for young patients for fertility preservation, yes, we can use it. I personally don't have experience of NACT in clear cell. Yes, we have used NACT for 1B3 tumors, and they do respond beautifully. Majority of them, at least squamous cell carcinomas, the tumor size decreases, the depth of invasion decreases. And in fact, two of our patients at the post-surgery, there was no residual tumor. So whenever in a younger patients, yes, I think we can use NACT, but I don't know about clear cell carcinoma, how beneficial they are. In fact, some studies have shown in long term, they do worse outcomes post NACT. So I cannot say much about clear cell carcinomas.
Okay, yeah. So basically, you're absolutely right, because clear cell carcinomas are so rare. So we only have some sporadic reports. But I came across a very interesting case report in which there was a triplet pregnancy. The woman was pregnant and she was diagnosed to have as a clear cell cancer. However, she refused to, abort. And so they started her on chemotherapy, and by the end, they could salvage the babies. And they also did a radical hysterectomy at the time of cesarean section. The tumor had shrunk in size. So basically, it's a case-to-base assessment to individualize the management as what the patient clinical features and desire for fertility preservation are. Absolutely right. Next slide, Dr. Ashok, please.
Again, it's not.
It's again stuck. Is it moving?
No. Yeah.
Yeah. Next slide. We've discussed this already.
Yeah.
Next slide. Yeah. Next slide again. Next slide also. So, Dr. Vishwajit, as we are deciding around for CCRT in this patient, anything which we can do to improve the morbidity from radiotherapy? This is a young patient, 35 years old. Dr. Vishwajit?
Can you hear me? Yes.
Yeah, we can hear you now.
So, surgical modifications for this patient, if you ask me, I don't think if you are thinking of ovarian transposition, I would suggest I will not go for it. Personally, I don't believe, and I'm not in favor of ovarian transposition in cases of HPV independent and rare variants specifically, because they have a bad prognosis, they have poor prognosis. Evidence, if you ask me, yes, there's no level 1 evidence. Even if there is, if you go to the recommendations or the ESGO update on cervical cancer management 2023, it's a level 4 evidence. The retrospective studies are there, and there's a grade of recommendation is A. So they also don't suggest to go for ovarian transposition in HPV independent variants, and also I would also do the same thing, and also in Silvasi pattern of HPV dependent cancers. This patient has got has got to his para 2. Although hormone for preservation function is important, still I would not go for it.
Okay. And so, yes, as we discussed earlier, also in the first lecture, Dr. Jaideep also said that, we are quite, although there is no well-defined contraindication of ovarian transposition in adenocarcinomas, but yes, as you said, it is a non-HPV cancer, this one clear cell. So yes, we will definitely take it with a pinch of salt, and we will, we'll always be apprehensive of transposing the ovaries in this case. What about omental spacers? Do you have any experience with the omental spacers during a radical or
no, I don't have any personal spaces, but yes, there are studies and there are case reports. So not aware of evidence.
Yeah, so actually, yes, actually, there are no, studies, large data regarding omental spacers, but yes, in various other cancers, they found that omental spacers do reduce the bowel toxicity, and it is useful, especially when you are planning, whenever you see a high risk cancer, and there's a risk of re-radiation also when we are during recurrence. So I have a little bit of experience with omental spacers when I went for my training. So there, during the time of radical hysterectomy, they used to mobilize the omentum, and they just used to place it just behind the vault. So and the radiation, even the radiation oncologists there they had some data around 35 to 40 cases which they had done in a few years. So they said that it does reduce the amount of the symptoms of the bowel syndromes are reduced with the use of omental spacers. Maybe they will come up with a publication in 1 or 2 years. But yes, during the course of radical hysterectomy, I think not in this case, but when we are doing radical hysterectomy, we can do mobilize omentum and we can put it behind the vault. And that has shown to be useful, especially in the higher cases when there is a probability of an adjuvant radiotherapy. Okay, so next slide, please, Dr. Ashok. So prognosis of HPV independent, Dr. Padma, we have already discussed earlier, but just to complete the case.
Yeah, as we had already discussed, as such, adenocarcinoma, it's not a very comfortable disease, all the more when it is a non-HPV related one. And among the different subtypes, gastric type is said to have a little better prognosis compared to the other ones. But personally, I don't have any big experience about clear cell carcinoma and all. And but the only thing is, clear cell carcinoma probably arises out of the endometriotic cell rest in the cervix, and as such, it's a very rare primary malignancy of the cervix. And
So yeah, actually, you're absolutely right. The prognosis is definitely worse than the HPV dependent. And they found that the overall survival, especially most common factor to determine the OS, is the stage of the disease and also the tumor size and the age of the patient. They are the two other factors which are accountable for the overall prognosis of non-HPV dependent adenocarcinomas. So next slide, Dr. Ashok. And I think with this, we have completed our second case also, and we have dealt with both the HPV associated and with the non-HPV associated adenocarcinomas. Next slide, Dr. Ashok. Thank you so much. And I think Dr. Shalini, I just saw the message, ma'am is back. So ma'am, any comments from you regarding the
Actually, I was busy with something else. So I listened to the end of your omental spacer business. But in clear cell carcinoma, I think we have to, isn't it an indication for omentectomy? Can we use that omental spacer in clear cell carcinoma?
Ma'am, this is cervix.
Cervix, you don't have to remove it, but I thought clear cell carcinoma of the endometrium and ovary we do remove, but in cervix, I don't know what is the,
In clear cell also, the guidelines don't say omentectomy, but in serous and undifferentiated carcinosarcomas, they are removing the omentum.
Okay.
But cervix, we don't remove the omentum. I don't
Cervix
know.
we don't, yeah, but somehow the clear cell pathology is a more aggressive pathology. So at least in ovarian and endometrial, cervix we don't. So what is the opinion of the house of the others? Yeah, I don't think you would remove it in cervix.
So,
Regarding
Madam, how there?
yes, can I
Yeah.
regarding the omental spacer, we are regularly in radical hysterectomy, we are regularly doing it. If the omentum is short, we just raise a little bit, make a flap, and we are really placing it. So I don't know how much benefit the patients are getting, but we are practicing it.
Yeah, it actually, there is no studies, there are no data available. I mean, proper studies available. But yes, in whatever experience they were assessing that time, and they did find that the bowel symptoms, especially the small bowel, the diarrheas and all, they usually were less with the subset which had the omental spacer.
So maybe the large bowel gets more protected. The large bowel probably gets more protected with the mental spacer, because the small bowel will be moving freely. The mental spacer would be covering the rectosigmoid, right? So the diarrhea and other symptoms may be less.
Small bowel will not
Is
get
that the
stuck up.
mechanism?
Small bowel will not come into the field.
So one question just for Salini Madam for his expert opinion. Just we are discussing the previous case. Though our patients are received CCRT for the LACC, locally advanced cervical cancer. After that, he came back after 2 months with the residual lesion of fortium. So what is the role of salvage hysterectomy? So is there any experience from your side,
What is
Dr.
the
Salini
role
Madam?
of salvage?
Salvage hysterectomy or a residual lesion of 4 centimeters. Initially,
Yeah.
it
If
was
it's operable, you get an imaging study done, your clinical examination imaging studies, and if you think it is centralized or even if it is extended laterally, you should, and you're able to get a clearance, you may consider a salvage hysterectomy, because especially if she's recurred early, then
he recurred back. He came back to us after 2 months with a residual lesion of 4
so
centimeters.
so there is, and recur after 2 months with full course of CTRT, right?
So it's a residual disease. We cannot tell it's a recurrence. It's a
Yeah,
residual
residual
disease of
disease. So
4
she cannot get RT again so soon.
Yeah.
So you can't give her RT. So you'll have to think of either chemo or surgery or targeted therapy.
Yeah.
I'd like to
considering the early recurrence, probably it is a resistant disease.
Can I say something?
Yeah, sure.
I'll go with Dr. Vishwajit on this, because 2 months is very early because the effect of radiation lasts for a few months. So it is a persistent disease, because as per the definition, 6 months is the time limit where you say whether it's a recurrent disease or a persistent disease. It's not that you see the patient after 6 months. You should be aware that there is a persistent disease. Personally, here we are operating on residual disease centrally located, but then we definitely wait and closely watch them for a few months, then take a call, because the effect of radiation generally takes time. So we have.
What are the common morbidities you face during hysterectomy?
No, Upasna, once you have a recurrence or whatever mass comes back and you take a biopsy and it is proven to be histopathologically positive, you can't wait for the effect of radiation for a few months for observation. I think you have to act, because it's going to grow. If it's a malignant,
We're talking about residual disease. So residual disease, should we operate at 2 months or should we wait for longer? Actually, that question is that.
I know.
Can I add on to
understand
that?
Guidelines, you have to
We
take
do
a-
wait for 3 months, but I totally agree with Shanley Madam that when you're seeing a disease at 2 months, you don't wait, you operate then.
So,
The
ma'am,
ideal time is sort of 3 months. You wait for the RT effect for 3 months at least. But then when there is a clinical disease at the end of 2 months, you take a biopsy, prove it, and go for a salvage hysterectomy like this patient is operable. So you don't wait for another 2 months or 6 months.
Yeah, I don't
At
think
that
we
point,
can
when you
wait.
have a disease, you operate. And about the mental spacer, we used to do that. But now for a long time we have stopped because there is no evidence for that.
Yeah, there's no
And
evidence.
it's actually, if you do radical hysterectomy, you don't expect the patient to get, you don't want your patient to get RT. So it doesn't actually help. Other than absorbing some lymph from there, the momentum is not going to help you. We used to do that. So many cases we did some 10 years back, then we stopped. So
I think
momentum
Amita
is
ma'am is
probably
back.
not going to help you.
Can we have our expert opinion on salvage hysterectomy and women health specialist. Amita ma'am, out there. Dr. Amita is not there.
Dr. Amita was actually traveling, so she must be
Yeah. So,
getting in and out of cabs. I don't know.
So get a message that she's back. So that's all. Okay, so over to the organizer.
Thank you to all the panelists for such inputs, and thank you very much for such.
Thank you, Dr. Ashok and Bindya, such beautiful cases and a nice discussion.
Thank you. Thank you, Shalini ma'am, for giving the.
Thank you. But I wish I could have been there. I had to go in between. Very interesting discussions going on and a lot of learning. I think every webinar you learn a lot, and both you and Ashok's case, I think Ashok's case I did listen to. Your case seems to be a clear cell carcinoma of the cervix.
Yes.
Okay. Yeah. So maybe if there is a recording, I'll Bhagya, is there a recording? I will listen to the rest of it later.
Yeah. We'll send the slides to you.
Okay, nice. Congratulations, both of you. It was an excellent, and all the panelists, I think.
Thank you so much, ma'am.
It was an excellent
Bhagya ma'am, are
discussion.
you there? So
Bhagya
I have to
is
go
not
for
there?
vote of thanks that ma'am is not there.
Okay, so I think you can conclude. You and Bindya can conclude.
Yeah. So again, I'm thankful to all the panelists and our experts, Dr. Amita and Dr. Shalini ma'am, for their valuable inputs of this session. And in total, also, I'm thankful to the organizers, starting our President, Dr. Rupinder ma'am, and Dr. Amita ma'am, past President of AGOI, and this organizer who is organizing the persons who are just audiovisual persons. And I'm thankful to all the audience for a nice and this nice CME. That is.
I think it was a good selection of topics because you're all the time listening to prevention. So this time, the selection of topics was very good. All 3 topics were very good, and this discussion was good because adenocarcinomas are rarely discussed, and so that was a good this thing. And I think it was an excellent end of the month webinar on cervical cancer elimination. Thank you all. It was wonderful.
Thank you all.
So much, all of you. And I don't know why all through with my this thing, the name of Upasana Barua kept coming. That was.
Who's Upasana Barua and who she's not? She's Upasana what?
Is there, but at 2 places. I do not know why and how. Anyways,
she's Upasana what?
We do recognize you. Yes, I don't know. Everybody knows you. You are a very familiar figure.
Yes, Dr.
She's Upasana Barua written on top. Oh, okay. And what was written for Upasana?
That's all right. That's okay.
And what was written for Upasana?
It's right name for her.
Was she called Nisha Singh?
No.
Everyone knows you, Nisha. Koi baat nahi.
No, that's okay. It was just a lighter